Hello and welcome everybody. Can you hear me okay? I just want to let you know, you can use the chat or the Q&A. We'll be monitoring it throughout, and just want to welcome you here today. We are going to get started on time because we have a packed webinar. We only have an hour, and with any luck, we'll have time for some questions. I'm so pleased today to be able to welcome you. This is our December Dementia Care Aware webinar. The topic is next steps in assessment and management after a positive cognitive health assessment. And I'm Anna Chodos. I am your speaker today. So we'll be a little lean and mean on the speaker front. And I'm also very privileged to be the executive director of this program. So I have no financial disclosures, and briefly our outline for today's talk. I'm going to start with a quick review of kind of where we're at and this roadmap of the process of starting screening and then doing evaluation and care for people with cognitive symptoms and functional symptoms. So I want to review what the cognitive health assessment is in case you happen not to have seen it yet or to have done the training, and also just in case you need a refresher, and also what we mean by a positive cognitive health assessment. We're going to also just quickly review what starting a brain health care plan is right out of the gate, because it's so important. And then we're going to really get to the meat of the topic, the next steps in evaluation. And I want to signpost for you guys. What I'm going to do is really bring your attention to the points I want you to take away during the webinar and during kind of each section, because there's a lot of information here. It's lunchtime, so I kind of can't help myself. This is, for lunch comparison, this is a heavy lunch. This is a plated steak lunch, side of potatoes, or if you're vegetarian, multiple portobello mushrooms and vegetables. You're going to be really full after this talk. So I want to really pull out for you the things to remember, at least for now. And of course, this information will be available later. We'll keep going over it. We're going to add to it. But this is something I hope you can sit back and kind of really just digest with me here, and take away some points if you're starting to do these screenings and really want to get going on next steps, which of course we all know is super important. We do have some learning objectives. I hope this is what you take out of this talk. I'll let your eyes run over this and read our learning objectives. And this is really, we designed this so that you could get continuing education credits and come away with some learnings. So hope that this is effective for you. And I'm going to dive right in. Again, I said this is a big meal. We're all going to be drowsy afterwards after going through all this information, but I really want you to take home the essence of why we're getting started in detection of dementia with the cognitive health assessment and what it is. Again, if you did the training, hopefully this is a refresher. But if it's new information, it's always good to go over these things more than once, right? So the cognitive health assessment, we've designed it as an annual assessment, essentially a screening for patients ages 65 and older. The goal ultimately is to detect if someone has cognitive and functional symptoms that would ultimately get you to understand if they might have dementia, which I'm going to review again. And so if we're trying to get to a point where we know and identify who has dementia so we can care for them, we need to do this quick check on cognitive and functional symptoms. So that's what the CHA is. It's a quick check on cognitive and functional symptoms in kind of a screening mode. We also, however, added an assessment of the person support system, because that is a foundational piece of how we're going to care for somebody if they do have a dementia syndrome ultimately. So it's really just the start. It's the first pass at where we would detect something that needs a further diagnostic assessment. Again, the topic of today's talk. And it is an opportunity. It's an opportunity to jumpstart brain health, which I'll review briefly after this. We structured the cognitive health assessment, this quick check on cognition, function, and caregiver or care partner resources, as a brief history, using screening tools to get more information about cognition and function, and then documenting, again, briefly, if there's a care partner in that person's life or more than one, and what their information might be for contact information. Why did we structure it this way? Well, the cognitive and functional decline are the core components of a dementia diagnosis, so we have to get some information on those. And as I already mentioned, the care partner is going to be so crucial, or knowing if they don't have a care partner, all of that's going to be so crucial in helping to support that person. What do we say is positive? Like, why would you do it? Or why would you decide to do follow-up evaluation after doing the cognitive health assessment? That's if there's a positive history. So I have a symptom or somebody's noticed that I'm struggling or having a cognitive symptom or decline. And if the screening tool for function or cognition is positive. I'm not going over the specifics of the history or the screening tools right now, just because we've done that in other webinars and it's in our training. So again, this is really a brief overview review. But if any of those are positive, we're going to go on to this next steps piece, which is the topic for today. Again, why is that? The dementia is a syndrome that's defined in the DSM-5. It's defined as a new, so acquired decline in cognition and function, so a change from a baseline. So we have to establish those things. And so that's the place to start with the screening, asking about cognition and function. The other piece, which I know many of my colleagues in primary care and physicians in general are pretty good at thinking through what other causes of cognitive and functional decline could be and how to rule those out. However, I want to dig into that a little bit more because that's clearly a focus of the next steps in evaluation. So what do we really mean when we say no other causes? What we mean is we're ruling out and we're finding information to suggest that there may be a contributing or reversible cause of this person's cognitive and functional decline. And what we're really saying is that these causes aren't neurodegenerative disease. We say dementia, and that's a syndrome, right? And ultimately, we want to be able to identify who has dementia. And then the next step is in this evaluation is really determining what might be contributing to those symptoms and ultimately trying to figure out if we really think the underlying cause, the true cause, if you will, of the dementia syndrome is a neurodegenerative disease like Alzheimer's disease, like vascular dementia. So we have to rule out all these other things. However, it's not necessarily the whole picture of figuring out what is the cause and what is that underlying disease. It's distinct. It's just making sure that there aren't these treatable, reversible causes. There really aren't, as we know, the truly reversible causes. There aren't that many, but there's so many contributing factors that if we address them, really help that person do better, that of course we want to assess for those and identify if they're playing a role. So we're going to go over these again, but I just wanted to take a moment and acknowledge that the no other causes, it's kind of part of that process of ruling out other things we can address. And so I'm going to come back to this. This is a bit of a roadmap for where we are with getting to that place of knowing if this person has a neurodegenerative disease that is causing dementia. And we start with the screening. That's where we have this opportunity to start understanding what's going on and to really start care planning with that person. We can start a brain health plan right away and plan a follow-up visit. So that was the CHA and what we've talked about already a little bit on these webinars and in our training. Now we're at next steps. What do you do next? Again, we're always, for me, and I teach it this way because this is how it really works for me to kind of keep a handle on my assessment and my care plan with the patient. But I really stick to the foundational pieces of cognition, function, and care partner. So I just want to acknowledge, we did get a question in the Q&A, and I will get to that. Thank you. So we go deeper on the history, we go deeper on the diagnostics and the exam and diagnostics to look for other causes and contributors. And another thing we're doing in the next steps is looking for red flags. And what do I mean by red flags? At the end, I'm going to mention a couple toolkits for reference that are these incredible toolkits that will also help ground us in kind of why we look for red flags. But essentially what we're saying with red flags is that there may be a condition that's neurodegenerative, so that person is slowly losing brain cells, that isn't Alzheimer's disease. So red flags is often shorthand for something else going on that might be treated in a different way, might have a different prognosis, or we may really need and want a specialist to help us with the management of this person. So typically red flags are referring to non-Alzheimer's signs. This person does have neurodegenerative disease, but it's not Alzheimer's, which kind of has this slow and steady course and doesn't often necessarily need specialist help, although it could. The other piece of the next steps, as you will see by my incredibly delicate and artful diagram here, is this recurring arrow, which is often we're spending a lot of time in next steps. Next steps does not need to get done in one visit. Next steps is not an urgent issue often. We can break it up. So I'm, like I said, going to give you a lot of information about what can happen in the next steps evaluation, what we'd recommend, but you can break it up and you can kind of have your template and work through it and not try to get to it all at once. I personally realize that is very impractical for most clinic visits. So breaking it up either by what you're doing, like history, exam, or diagnostics, or doing a little bit of each and doing those in parallel. But it's going to take a minute. And then often it takes months, a year to feel comfortable. Okay, we've ruled out other things. I really understand what's going on with this person's cognition and function. I feel comfortable delivering a diagnosis of dementia. And then once we have that, and we'll talk about this in the future as well, we'll talk about how we support people with functional decline, cognitive decline, and any contributing medical conditions or causes of those symptoms. Throughout, we're working on brain health to support that vulnerable brain and strengthen it, and connecting to resources. And that's, of course, when we're working with a care partner and the person's circumstances and trying to figure out how we're going to support them. We're doing that all along at any point in symptoms really is appropriate. Okay, and then just a reminder, when we do get to that diagnosis piece, which it's hard, and I really want to acknowledge that it's messy, right? Or it's not always a slam dunk in the sense that we don't have that one blood test. We don't have that one imaging finding that really gets us to absolutely this person has dementia because of this one criteria and this one finding. We are piecing together these clues from different sources, trying to get a full picture of the elephant, as it were. So just give yourself that pep talk that it's okay to break it down and to just continually go back and figure out what pieces of information you have and what you might still want to know about their cognitive functioning, their functional functioning, their daily abilities, and any contributing factors. And so we're often doing that by asking about symptoms, doing direct testing and observation of function and cognition. We're doing diagnostics like head imaging and labs, and we're getting collateral information throughout if we can. I want to acknowledge a hand raise. If you are able to put the question in the chat or the Q&A, that would be really helpful. But if not, I will definitely get to you at the end. Okay, so then the other thing I told you in the beginning is I wanted to review with you briefly is the brain health plan. The reason we really emphasize this is because the brain is a very useful organ. If we can support the brain, we can support that whole person. They might do better in managing all of their other health conditions. And it's just something we probably shouldn't wait on if somebody is having symptoms. The reason is it's really non-specific. Even if after a year we get to a very clear place where we feel like this person has a progressive decline, this is meeting all the criteria for dementia, we would implement those things at that stage, of course, but they're all pretty non-specific. We can do it earlier. It doesn't hinge on what that exact diagnosis is. And at the end of the day, this could really help even symptoms get a lot better, right? They could look a lot better if we're addressing some of these things and help us get a clearer picture anyway. So those things are really briefly hearing and vision. So you can, of course, ask people, but often people don't know that they're losing hearing. So a hearing test is a great addition to a brain health plan, as well as vision tests, which people are more likely to notice and report and want. Connecting to physical activity and social activity opportunities. I realize this could be a whole talk on its own, but if we're really encouraging people with those lifestyle interventions, these are huge brain health interventions. The other is doing our best to remove any medications that might be causing cognitive side effects. I'm going to go over what those are in a second. And as I know you probably already do really well as a primary care team member or provider, helping to control blood pressure and diabetes within reasonable goals for the individual, knowing that the older we get, the other comorbidities we have, a lot of these goals get slightly loosened, as it were, depending on the condition. But these are big brain protective factors. So medications, what am I talking about? Which medications cause cognitive symptoms? Which ones do we want to start to peel away? The main offenders are things with cognitive side effects, sedatives, like intentional, cognitive impact, like we know they're getting crossing the brain blood barrier, and anticholinergics. So anticholinergic burden is a huge deal. It's in a lot of it's a characteristic of a lot of medications that don't label themselves as anticholinergics, like oxybutynin, which is a big offender, but is a known anticholinergic. Diphenhydramine is probably the one that's over the counter, and it's in all these Tylenol PMs, and probably everybody's reaching for something with PM on it these days because they all have colds and we all need to sleep. These things can cause a lot of cognitive side effects and are at risk of more rapid decline or even developing dementia. Benzodiazepines, again, big no-no, huge delirium risk, especially in people with dementia, and not worth the long-term side effects. Other medications like other sleep agents like Z drugs, muscle relaxants, TCA, antidepressants, and antipsychotics. Every single person, really except for the benzos, maybe if there's panic disorder or alcohol withdrawal, but most of these can be substituted with something else that's safer. I know that people with serious mental illness, of course, may need high-dose antipsychotics. That is an individualized risk benefit, but just to be aware there are cognitive side effects. So something to be aware of. Okay, so we just briefly reviewed the cognitive health assessment. We briefly reviewed the brain health plan and how we can just get started while we're working on these next steps. Broad overview. I'm just trying to remind us where we are in that little roadmap I showed you. In our next steps, we want to get deeper on the history, start to rule out causes and contributors to the symptoms we're seeing, and look for red flags. And we're doing that as we do with any other condition. We're getting a detailed history. We're getting exams, and I include kind of questionnaires and surveys about different conditions in the exam portion, although I think a lot of people might include it in history, but just to acknowledge that. And then we can get some diagnostic information like imaging or labs, and I'm going to go deeper into all of these things. The first, though, is the history and the cognitive history specifically. How would we do that? And again, as I am deluging you with information, please know you can break this up. You can think to yourself, you know what, I'm only going to ask these 3 questions at the next visit. I'm not going to do all these cognitive history questions. So just want to be really generous and just say, you know, I really am not trying to say this all needs to get done in one visit. But when I think about getting a cognitive history, my framework is one, there's a lot more domains than memory. I think memory is the big man on campus. It's had its reputation as being the harbinger of dementia forever because Alzheimer's has prominent short-term memory symptoms, and it's the main cause of dementia for many, many people, for the majority of people. But lots of dementias cause symptoms in other cognitive domains at the same time or without any memory impairment. So it's important to have a sense of the flavor, the overall picture of all these other cognitive domains. And that is my objective in the next few slides, is to go over those other domains and what you might ask, like not just to tell you about the domains, but how would you ask somebody if they're having trouble? And then the thing I'm listening for is I'm trying to understand what symptom they're having. How's it been going? Did it start a couple of years ago and getting worse? Is it a new symptom? Is it actually getting better? So trajectory is important because in the back of our minds, we're thinking if they have a dementia syndrome and they have a neurodegenerative disease causing that, they should be getting slowly worse. But some things like behavioral symptoms come and go. So it is just valuable to understand the trajectory of these symptoms. And then how severe. So this is where we all know, we all have what we call cognitive failures. I lost my phone. I lost my credit card the other week. I, was at the meeting at the wrong time, wrong day. Whoops, that's not normal. But how severe is this happening? Is it happening all the time? Is it affecting your daily life? That is a stronger indicator that something real, if you will, is going on. And then, like I said, it's okay to break this up, to decide that you're going to only ask about a few things at a given visit. Whenever we can, we need to try to get collateral. It's a nature of this disease that people may not report accurately. They may not know or realize that they're having a symptom. And particularly behavioral symptoms may be underreported or not reported accurately because they may not notice, or it may be most noticeable to somebody else. All right, so I'm going to go over the domains quickly and some questions you might ask. And I'm seeing some really good questions. I just want to make sure everybody knows I see them and I'm going to answer them all. We should have time. So first domain, memory. We all got this one. This is the poster child for dementia. So-and-so can't remember. They're repeating themselves. I told them this, what you don't remember. Oh, they forgot an appointment. They're forgetting to pay things. They can't learn new information. This one, I think we all have a better sense of because it's just a more common symptom to be reported and it's very noticeable. But you could ask the person, has your memory become worse? Of course, this was potentially a question that we use for the CHA screening as well, depending on how you got that positive history. How would you ask somebody else with them? I'm just going to use the name Andrew for this talk. Has Andrew's memory become worse? That's how you might ask an informant. Executive. I think this one's tricky. I try to think of it as an executive doing their work. They're doing busy things. They're doing lots of things all at the same time. They're planning. They're executing on multiple tasks. So they're a planner. They're a multitasker. Those are the kind of things that get affected with executive functioning, among other things, but it's a good entry point into trying to see if they're having some symptoms in that area. So you can ask about difficulty managing daily tasks or like shopping, which used to be easy. Do you have difficulty planning ahead or staying organized? Might be a question. Has Andrew had more difficulty planning ahead or staying organized? Another domain, language. This one also pretty typical. A lot of us notice word finding difficulties as we're getting older. People report it, but it may also be paucity of speech or lack of bigger words, like people start to really describe things very vaguely. But you could ask somebody, do you have difficulty finding words you want to describe what? So that's a terribly worded question. So good example. Do you have difficulty finding words you want to describe what you want to say? I think you could probably find a better way to ask that question. Has Andrew had more difficulty expressing what they want to say? I certainly have. Okay, another domain, visual spatial, getting lost, not knowing where you are. The other one is like having trouble with curbs or parking. But in any case, I think a very clear question a lot of people know to ask is, any difficulty finding new places, getting lost in familiar environments? Has this person gotten lost? Has Andrew gotten lost? Attention. Attention can be really problematic if people are having a lot of trouble, right? Because they can't do tasks with you. They can't focus on a conversation, potentially super tangential, maybe drowsy. But anyway, the general idea is more difficulty with concentration, maybe fluctuating attention. And we can ask something like, do you have increasing difficulty focusing on things, focusing on tasks? Do you have trouble paying attention to things you like to do, like watch TV or play a game or do a word puzzle? Has Andrew had increasing difficulty focusing on tasks? And then this one I think is a kind of doesn't necessarily appear to be a cognitive function. It's clearly a brain function, but intentional movement is really a cognitive function. And there's a lot of motor symptoms, especially over time. If you think of advanced people with dementia, they have tons of motor symptoms. But common questions we can ask are, any trouble changes in walking, any trouble with tremors? Have you had any falls? Has Andrew had any falls in the last year? Might be something we could ask an informant. And then this is the last domain, and it's a big one, behavior. Essentially, everyone with dementia will have some change in their behavior over time. But big ones that come to attention because they're symptomatically really problematic for people might be things like inappropriate behavior, eating strange things, lack of decorum in settings where they used to. Obvious changes in mood or emotional health might be something the person themselves is more comfortable reporting. Things that another informant might notice is, has Andrew's personality or behavior changed? Hallucinations, delusions, people can report often and may do so without any real insight that it's a delusion, of course. The other one is sleep disturbance. Sleep is kind of its own cognitive function or brain function, but sort of bucketed in here, and a lot of people also have sleep disturbance, and that can be worth asking about too, if that's a question you want to add to your inventory. Then, as I already mentioned, we're going deeper. We're looking for contributing causes that we can address, and we want to look for red flags as we go along in this evaluation. And when it comes to the history, the things that should go ding and tell us, this may not be a typical Alzheimer's cause of dementia, or something else might be going on here, is younger onset of symptoms, rapid decline. And it can be hard. Most people will always, in fact, almost everybody asks, oh, I've only had symptoms for like 6 months or a year. And it may be that they just noticed it then, sure. And that can be hard to suss out. However, what we're really talking about is like pretty clear evidence that someone was highly functional and now they can't, they were running the household, they were working full time. Now they can't really figure out how to take a shower. They're clearly not themselves. These sorts of things can be, markers of really serious and more rapidly progressing dementias that obviously there's going to be really important prognosis implications. So that would be a red flag that you would want to think about maybe getting specialists involved. At the end, I'm going to talk more about the whole specialist and referral idea. The other is prominent aphasia or language concerns. So, and then the other is behavior changes that may be really, really prominent, really, really, I guess, unusual. So really prominent hallucinations and delusions without a lot of other cognitive symptoms, personality changes, like really inappropriate behavior, eating food off the street, saying inappropriate things, and that was never them, being really disorganized. And they were a high performer before and like really disheveled and not aware that, their hygiene or appearance is an issue. And again, just to emphasize, essentially everyone has behavior changes if they have dementia at some point. But when it's really early, really prominent, really like took a hard right turn from who they used to be, those are the folks that we should raise some additional suspicion that maybe something like frontal temporal dementia or another cause is going on, and this is not standard Alzheimer's, and perhaps a specialist would be helpful in helping figure that out and manage. Okay, so fire hose of information, all about cognitive symptoms. Just to reiterate the main points, we were looking for some red flag symptoms. We were going deeper on the cognitive symptoms, the when, how severe, what exactly are they having in terms of different domains and areas. And over time, all dementias are whole brain. Dementia syndromes are usually due to whole brain diseases, and people will have symptoms in all those areas. But the pattern of when and what happens is about that person, how we're going to support them, and ultimately, again, if we're finding any red flags, how we might connect them to another level of care. Telling you guys about doing a more detailed functional history is definitely a lot simpler. So again, we just want to go deeper. We really want to understand how this person gets through a day, what they, how they do their daily functioning and tasks, How we ask about that is some tips I'll give you on the next slide. But it's the same domains that we kind of screen for if you use our checklist for asking about activities of daily living or ADLs and instrumental activities of daily living or IADLs. It's the kind of the same information, but just deeper. And if you can, spending some time getting a collateral report. Maybe you got all this information in that initial screen because you gave them gave an informant a piece of paper with all of these on them and they indicated what they need help with, in which case, great. A lot of times though, we might need to spend a little more time getting information, excuse me. And so how can we do that? We can say things like, how do you do your bath? Like, tell me about your shower, your setup. How do you take a bath? Does anyone help you with cooking or cleaning or shopping? Have any changes in how you've been doing these things? Pandemic changed a lot of people's routines. And I think a major point here is a lot of people say, nope, I don't do the finances or I don't do the cooking. And that's just how it's always been. So this is also an opportunity to figure out, we're looking for delta, we're looking for a decline. So understanding if that was something they ever did. And in many, many households, these duties are split up. So it may not have been something they ever did. And just another little tip, I usually say, I start to talk to people about like, just tell me about a typical day, like what you're doing and how you're doing those things. So are you going shopping with your husband, daughter, friend, or are you, are you usually alone and doing those things on your own? So that's how I sort of normalize trying to understand these functional needs, because obviously a lot of older people feel infantilized if we're asking about like how do you dress. So just getting a sense if they need help in those things. Okay, so functional history a little easier, and then exam. What are we looking for on exam? So I want to address the issue. Part of the exam might be a cognitive test. You might say, okay, they had a positive screen. I'm going to do more positive CHA, positive screen. I'm going to do more cognitive testing. If you are comfortable and you feel good about doing additional cognitive testing, by all means, I think that's great. And if you feel, you have the time, I think in general, I think of the cognitive testing as helping us really bucket people as, okay, they're giving me a lot of symptoms. Their test kind of supports that they were really struggling in some areas. I'm more likely to put them in the bucket of like truly having impairment versus not. I think we need to emphasize, especially as we're serving such a diverse population in California, a MoCA test and MMSE doesn't make or break a diagnosis, because we still need those other pieces of how are they functioning? Do they have symptoms? There's so many reasons for that. And I do want to emphasize, if you are comfortable doing these tests, and I'm 100% certain we're going to have more talks, webinars, information about the different tools that are out there and how to use them, how to think about them, what populations have they been really studied in. But one of the issues with some of these tests is they're not actually that normative, meaning the people that they study these tests in to divide normal versus abnormal were very different than the people we're using them in California, from all these different backgrounds, educational backgrounds, cultural, language, and may not be a good comparison, because essentially what you're saying is if you do badly on this test, a SLUMS or a MoCA, well, then you're not normal. But that normal was defined by a certain group. And if that group doesn't look like the group you're testing, it may be off. And I guess what I see is a lot of people get like a 15 on the MoCA and they're actually doing pretty well. And a 15 would be, pretty bad, but they're doing really well functionally. There's not a lot of other indicators that they're having trouble in their day-to-day life. And I just want to emphasize, it doesn't make the diagnosis just to do these sorts of tests, but it can help you walk down that road of, okay, I feel additionally supported in this idea that they are having some issues, they're impaired, they're struggling with these domains. And of course, we always want to take that into consideration with who's the patient. Is the test I did actually a good reflection of their abilities? The other issues, of course, we have all the time are like, how long is this test going to take? Some of these take about 10 to 15 minutes. That can be too much time. We may not have that time. Can we get a copy of it? Is it freely accessible? And then what I would say is also, does it come with instructions? And I'm the kind of person who never read instructions. I recycle it immediately with any box of anything I buy. But this is an instance where you do want to read the instructions because it's not actually obvious how you're supposed to give instructions about how to complete the test. And you're basically giving a different test if you do it that way. So I would say, does it come with instructions? And then for really impaired people, people who are struggling to do their activities of daily living, they need a lot of help with bathing and dressing. In a basic conversation, they're really struggling to get through answering questions or just saying yes or no to everything, looking to someone who came with them for all the answers. That may not be somebody who can even really get through the test, and that's okay. You have other evidence that there's impairments there. You don't need this kind of direct cognitive testing necessarily. So I just want to also point out that if somebody's really impaired, it may not be a good use of time. And then you're going to do a physical exam and a neurologic exam. I didn't necessarily want to go over the head to toe, but the things you're really looking for in this instance would be red flag things. So do they have any Parkinsonian features? That's a tip off. It may be a non-Alzheimer's type of process going on. So are they rigid? Are they cogwheeling? And then are they falling? And that may come up as you're doing their gait analysis, like are they steady? And for some reason, whenever I do a gait analysis, or like have somebody walk down the hallway, it always prompts me to think, oh, have they fallen? So I kind of think of that exam and that history together. The other is, are there focal findings? Are they unilateral? Do they suggest, is there slurred speech? Do they suggest that maybe this person has had a serious vascular event? And then the other one, and this came out of some of the toolkits, again, I'm going to highlight at the end, that is if there's difficulty with vision that's really not explained by objective eye exam testing, that could also indicate that there's another neurodegenerative disease that isn't totally Alzheimer's type and may benefit from additional specialist involvement. Okay, and then part of the exam that I think of, again, with the noticing the person's presentation, as well as doing some of these questionnaires for things like mental health symptoms, a substance use screen as part of your exam. Sleep apnea, they have the body habitus, they're really, really tired. Medications, of course, I talked about already. And then things like it's clear they're very acutely altered, they're fluctuating a ton, very inattentive. Maybe this is actually a delirium, could always be on top of other things going on, like a dementia, but always worth noting if the main cognitive symptoms are super acute and fluctuating, because those are things we can address. Just to point out, typically a mental health condition is never at a level that it's going to cause a full dementia syndrome, and it has a lot to do with that person's history. Do they have a serious mental illness that they've had for years? And so what we're really looking is for something that's may contribute to some cognitive symptoms, and we can address, we can treat, but not necessarily that this is the diagnosis. But of course, every person's different. So this is all information that we need to gather. And those are the main take homes for the exam. And so the last part is additional diagnostics. What labs, imaging are part of the next steps evaluation. So medical workup, again, I really feel like most people I work with in primary care kind of do this reflexively, but there are those few conditions that are theoretically totally reversible, like severe hypothyroidism, severe B12 deficiency, untreated neurosyphilis, and HIV disease. So all labs to check on top of standard metabolic CBC, things that we're doing for other causes as well. Or like other conditions, most patients have those labs checked in other circumstances. So these are sort of the additional dementia labs. RPR and HIV, of course, you can risk stratify your patients, meaning decide if they're really at risk for neurosyphilis or HIV. However, I will say we do miss a lot of HIV in older adults, and a lot of people there, syphilis has a different prevalence 40 years ago in different parts of the world. So as a general rule, I just send these things. The other is imaging. So if you have access to imaging, it does typically merit, if somebody's having cognitive symptoms, a head CT. An MRI gives you a lot more detailed structural information. And I always put why I'm getting the MRI so I can get them to comment on if they see any evidence of atrophy. But the reason there is really, is there something there that would change this person's life if we found it and treated it? A tumor, normal pressure hydrocephalus, things like that. So these are reasons to get the head imaging and really anyone with symptoms. But if it's hard to get imaging where you're at, or it's hard to get that patient imaging, the people to really push for it in are those who started having symptoms younger, under 65. They're having this rapid progression we talked about. They otherwise have a diagnosis that could mean something's going on in intracranially, like a cancer or HIV. They've had a head injury or a fall, and especially if they're on anticoagulants. And then if on exam you are noticing unilateral or focal neurologic findings. And again, this is to find and rule out things that would explain what's going on and potentially treatable. And then we've done all this workup. And I keep bringing up red flags. So what are the red flags? What would you do with those? Obviously, I hope that you guys have some support to do additional evaluation and expert kind of synthesis of what's going on. We have some resources for you that I'll mention at the end that we'd love to share with you and help support you as well. But often, if they're having those red flags of like rapid progression, language or behavior, predominant symptoms, new and serious behavioral symptoms, neurology, geriatrics, psychiatry, all hopefully helpful supports. Understanding that geriatric psychiatry is an incredibly rare specialty to find would obviously be fantastic if available, but our wonderful psychiatric colleagues, especially in our folks who've had lifelong serious mental illness or are having a lot of behavioral symptoms, would be great to involve them when we have that resource. I know it's very sparse in my clinical practice area, so I know that can be hard, as well as geriatrics. But these are some of the reasons I would recommend, if it's an option, to get them involved. And the other piece is neuropsychology. When do we need a neuropsych test and a neuropsychologist to see our patient and add to the clinical evaluation? Again, I just want to emphasize, if somebody's really, really impaired and they have trouble getting through a basic interview, it may be a lot to ask them to do a full neuropsych battery, which could be hours, and it may not really yield a ton of helpful information because you're kind of seeing in front of you that person's pretty impaired. So I often think about doing this in people who are a little on the milder side. I also think about it in people who they're having a ton of symptoms, but functionally they're fine. It can really help tease out what their actual deficits are and what's really going on with their cognitive functioning. And people with serious mental illness, they can often help contextualize this new decline or their new symptoms, knowing that they also have these other features that may be affecting their cognition, like a psychotic disorder or severe depression. So these are some of the things I think about. Of course, never wrong for you to involve your colleagues. But these are some of the sort of banner issues that I think a lot of specialists can be very helpful with. Okay, and then really briefly, and I think there was one question about this, although let me see. All right. Okay. So I just wanted to be clear, most of our older adults in California have Medicare, so there's some great opportunities to bill under the annual wellness visit. You can use the CHA as your cognitive screen and the annual wellness visit and your functional screen together and use those codes for folks. If you're doing this in next steps, though, it falls more under the 99483 under Medicare. And I think a couple of components were missing, which we'll get to, but I think there needs to have a safety assessment and a couple other features that this what I presented today gets you almost there. And this is typically meant to be a 50-minute complex visit. And so, but I think this would be an appropriate code for most of what we've discussed today. And then this program, in order to really encourage people to do cognitive screenings and dementia screenings in Medi-Cal only beneficiaries, of which we have about 250,000 here in the state of people 65 and older, you can use this new code if you've done just the cognitive health assessment. And our training goes through that in great detail. And we have a billing quick sheet coming out to support you in doing that. You do have to do our training and be registered. So I highly encourage you to do the training with us on our website. So let's just do a quick review, and then I've got some wonderful questions and I can't wait to get to them. I'm so grateful to you all for submitting these questions. Please continue to throw them in the Q&A. Sorry, hold on. I'll let you look at the diagram as I take a sip of water here. Okay, so where are we in our little roadmap? We did a screening. The screening allows us to identify if somebody's got some symptoms or a positive tool that we've done, identify how we can help with a brain health plan and get that started, and plan a follow-up visit. We've started our next steps evaluation, going deeper into cognitive symptoms, functional symptoms. The piece I missed clearly is how we're going to really address the care partner. That is our webinar topic for January. But all throughout, we're looking for some red flags and other causes, contributors that we can address. Because the more we do that, we may not get rid of all functional or cognitive symptoms, but we certainly stand a better chance of really supporting that person and helping them do better. And then once we've gotten through the next steps evaluation and chunked it out and gotten through it, we'll be able to feel comfortable saying, I've identified, this may not be how you want to present it. This is just how I'm talking to you as a fellow learner here. I've identified that you have a cognitive decline, a functional decline, and that really we've ruled out any clear medical cause or contributing factor that really explains all of it. This means you have something we call dementia. And what does that mean for you? Well, it means I'm going to continue to support your brain health, make extra special sure we're not doing anything to make your brain function worse. We're going to support your functional needs, and we're going to support your support system. So those are our goals. And we'll just keep working this roadmap, maybe even make it look nicer in the future. But thank you for bearing with me. And as we go through, again, at every level, screening, deeper evaluation, and diagnosis, we're thinking cognition, function, care partner, care system, care situation. We have so much still to talk about. I know you have tons of questions. Thankfully, I have time to get to the ones you've submitted today, but we're going to need to talk about more things. I really hope you stick with us, keep coming back to our trainings, our webinars. We're going to need to talk about how we really feel comfortable making a diagnosis of either mild cognitive impairment, dementia. We're not quite there yet. The new terms for those things are minor and major neurocognitive disorder. What does it mean to stage someone with dementia? A crib sheet on that is, it means function. We think about someone's stage as how they're doing functionally, but we're going to need to talk more about that. How we talk to our patients and their support systems about what we're learning, what we're thinking about a diagnosis, or at least where we're at in the process. How to really support the care partner. Again, that is next week's topic, next month's webinar topic. How to connect people to resources. And then we should go through a lot of case examples. Obviously, a 1-hour webinar once a month isn't the only way we can do this. So I want to guide you, at least for the next steps piece, to some really important tools out there. We have the CDPH toolkit, the Assessment of Cognitive Complaints toolkit for Alzheimer's disease, incredibly thorough roadmap for asking questions and sorting out red flags for non-Alzheimer's disease, and then how to support people with Alzheimer's disease. And then San Diego with Champions for Health, Alzheimer's San Diego, UCSD faculty and experts. They put together the Alzheimer's Project, and this has a beautiful toolkit as well, and some really nice sort of algorithms. While we sort of start to collate our materials as well, and really lean on this incredible work that's already been done in our state very recently. It's, these are tremendous resources. You can continue to learn about dementia and the CHA at our online training and get 1.5 credits for continuing education, get listed with us as having done the training. I really encourage you to do it now. After this talk, you'll breeze through it, and would really appreciate you checking that out. And then basically, if you can't remember anything else, you can always email us at dca@ucsf.edu or go to our website, which is still in development. Pardon our appearance during construction, but we have now a warm line where you can submit questions. We're doing it via email for now. Our goal is to get in the spring to have live people available to answer, like office hours, to help you answer questions. We're going to have more trainings. We have our ongoing webinars. We've just started recording some podcasts on these topics. We want to give you as many opportunities as possible to get CME and continuing education, as well as learn this information. We have interactive case conferences, echo style conferences you can sign up for now, and more coming. Also available to how you sign up on the website. And then if you are a practice, if you're a provider, and you want support to really hands-on, very involved support to help your practice get up and running with dementia screening and care, there's two amazing programs. One is the Alzheimer's and Dementia Care program from UCLA, and then the Alzheimer's Association has a health systems program, and these are meant to walk practices, like a primary care practice, through how to do dementia care and train people and give them lots of training support. So I shouldn't speak too much for them, but these are pretty amazing and completely available programs right now. So just want to encourage you to connect with us if those would be useful. I'm going to leave up this information for how to get credit for a few minutes and in the chat, I believe we have the links, so you can just click them and get your credit. Although I think I left enough time for that. I hope my staff agree with me, because I know I'm only supposed to open that at a certain point. Oh, you have to claim credit at 12:55. I knew it. I knew I messed up. My apologies. In the meantime, so only click on that link at 12:55. I'm going to answer some questions. Okay, sleep apnea. I did mention it during the exam, so I just wanted to mention it. Absolutely. Are you kidding me? Someone who's totally sleep deprived, like me today, can they function? Not very well. But yeah, sleep apnea. Oh my gosh, if we could. And some people really struggle to use the CPAP, and especially if people aren't housed, it can be really tricky, but it's absolutely a huge deal. I 10,000% recommend asking people about sleep apnea, noticing the signs on an exam, and having an assessment and treating that. I'm going to have to get back to you. Maybe one of our colleagues in the listening today could tell us about Medi-Cal coverage for vision and hearing screening. And the hearing aids, now that we have some over-the-counter support for hearing aids are, of course, tricky, because some people need quite a bit of support to use the hearing aids properly, like repeated adjustments and things like that. So it's always good to have an audiologist, if you can, work with them. But of course, there's this whole new program with over-the-counter hearing aids, which I actually haven't tried to access. Let's see. But if someone in the audience is more informed about Medi-Cal vision and hearing screening coverage, obviously we'll try to put out that information on our newsletter. So if you sign up for our emails, we'll send an update on that, what information we can find. But feel free to put it in the Q&A and I will read it. Okay, next question. Opinion on gabapentin. Yes, of course I have an opinion on gabapentin. First of all, make sure it's working, make sure it's helping that person. The risk benefit is really not there if they're not getting any benefit. They're only getting risk. So there's a principle of geriatrics, which I love to share, which is if someone's on a medication and it's not doing anything, it's literally only sitting in their body causing harm. So the main thing about gabapentin is if it's not helping, please just stop it. The other is at higher doses, it definitely causes symptoms, and the more vulnerable the brain, the more likely that's the case. So I would case by case, but assess for that person, is it helping, and have they noticed an association with the gabapentin initiation and cognitive symptoms, or have you noticed it? And I guess worst case scenario, although obviously pain is terrible untreated, if you can stop it, wean them off and see if they feel better. So gabapentin can cause drowsiness, some cognitive symptoms. Oh, and someone asked, how do you explain that memory is a different domain from the others listed? It's just a domain. And I guess the point is a lot of people, so for example, language prominent dementias, they'll just present with language issues, but their memory is okay. It's just one of many domains that we need to assess. It just happens to be, I guess, very popularized as the main symptom of dementia. But the truth is most people with dementia will have symptoms in all domains at some point, including difficulty walking, falling, behavioral issues, difficulty paying attention, difficulty organizing tasks. So I just wanted to really emphasize that memory is a domain among many, many cognitive domains. Next question. Do you recommend facilitating more than one test? I'm not sure I fully understand the question, but I think if it's about cognitive testing, I do recommend, I think it's a good idea you could potentially try a different test and see if someone does well. I think, and they didn't do well in another, but I think it also helps to have familiarity with different tests and kind of understand where they came from. And again, I would really love to have a topic on this in the future and hope to get there. I hope I understood your question, but I think I probably didn't. Do you always order imaging? So I would say the younger and the more unusual features, yes, there's definitely people like mid-80s, mild symptoms, very classic, mainly short-term memory, some difficulty with higher level instrumental activities of daily living, not necessarily, and no other symptoms. I think they're pretty unlikely to need, kind of by all the criteria, don't need imaging. But unfortunately, I'm now at such a specialized place. And I will say my colleagues in dementia specialty and neurology, behavioral neurology really, advocate for this very strongly. And so their answer would be yes. Let me just put it that way. Would you recommend genetic testing? Yes, I would refer to a genetic counselor if there was a clear, strong family history. And that's about all I can tell you. I've basically almost never had to do that. Most people are older, like over 70 and starting to have symptoms. It's unusual for it to be a familial thing, but might depend on the person's circumstances. Great. And somebody just made a great comment that they're working a lot with people who've already been diagnosed. And then, thank you for, I know I didn't get to you after raising your hand. And we have one more minute and I will get to, I'll try to get to as many of these as I can. Yes, we're going to have more webinars on assessment and treatment. And we are going to post a PDF copy of the slides. We also have all the other webinars with videos on the website, and we're going to add the slides to those too. What about proper documentation when assessing patient for immigration issues? Yes, I think as long as you march through what your assessment was and your thinking was around assessing their cognitive problems, their functional problems, you are able to make a diagnosis of dementia if that's what's going on. And I usually explain dementia means that they're having difficulty, and in their case with XYZ symptoms, they're having difficulty with learning. It's literally not possible for them to learn new information. For example, we reviewed that they can't do this, they can't do that. These are typical symptoms, and I don't anticipate that this person can learn the information for the immigration exam. So I just kind of explained what dementia is on the form and how I got to that diagnosis and why it affects their ability to learn. Yes, we're going to put the PDF PowerPoint on the website, and webinars are available later, and CPAP, and more about screening tools. And at UCSF, I actually don't know. Somebody asked, our PCPs at UCSF screening all patients for cognitive decline? I don't know, but we're about to start in our public health network as a strong recommendation. And it is somewhat provider specific though, but that is our recommendation. That is the end of the questions. I am eternally grateful to you for tuning in on this near holiday week. I know people have so much going on. We are so grateful that you would tune in. Please email us with any questions, comments, concerns, any way that we can support you in your care of these folks, and happy holidays to everybody. Thank you so much.